My colleague Simone and I will be moderating this session today. First, we will have four presentations from organizations working on the ground and also from research and policy. And then we will have a discussion that will be moderated by my colleague Simona. I will start with a few brief technical notes. We are in a meeting mode on Zoom, and this session is being recorded, as you might have seen. If you do not wish to appear in the recording, which will later be available in our website, please keep your camera and microphone turned off. Also, please remain muted during the presentations. We encourage you to engage with us. Feel free to ask questions or share your experience in the chat. Let us know where you are joining us from and what's your experience with today's topic in the chat also. Before giving the floor to our panel speakers, I would like to provide some brief context on the EU frameworks regarding hospital discharge and homelessness. Reducing health inequalities is an important part of the work we do at FEANTSA. At the EU level, the Lisbon Declaration of the European Platform on Combating Homelessness, signed by all the EU member states in June 2021, commits to working towards the goal of ending homelessness by 2030. One of its five key principles states that no one should be discharged from any institution, such as prisons, hospital, or care facility, without being offered appropriate housing. Additionally, I would like to highlight the Principle 19 of the European Pillar of Social Rights, which states that access to social housing and housing assistance of good quality should be provided for those in need. In this context, earlier this year, we launched a policy report on hospital discharge and homelessness in Europe. Exploring the intersection between homelessness and hospital discharge requires understanding how these issues interact and impact health outcomes, social services, and broader healthcare systems. Through this report, we examined the challenge faced by service providers on the ground. We conducted interviews with Emphasis and Pathway, both whom will also be presenting here today. And additionally, we explored the negative impacts of inadequate hospital discharge planning on people experiencing homelessness and conclude with a set of policy recommendations. You can find the link of the report in the chat. Now I will give the floor to our speakers. Hopefully this webinar will bring attention to this often overlooked issue, provides insight into the realities in different countries, and also explore solutions and good practices that have been in place. So I will just give the floor now to Maria Kara. She's the co-founder of Emphasis Foundation from Greece. Maria, you can start whenever you want. Thank you. Just Maria?
Yes, can you hear me now? Is
Yes.
everything okay?
Yeah, perfectly.
Okay, perfect. Sorry about that. I had a bit of a hitch. Hello, everybody. I am speaking today, talking about the situation in.
No, figurati. Ma no, ma anche di più se vuoi.
There is some interference, okay? Yes. So I was saying that I am talking about the situation today about about Greece and the system that exists in the hospital care regarding the discharge of homeless people. As you know, Greece has gone through a recession, a very heavy financial recession, and the healthcare system has been extremely fragmented since 2010. And with the influx of the refugee crisis after 2014-2015, it has actually deteriorated the situation and the health spending and the health budget overall in the country. One of the main issues that we are facing, and it had accentuated during also the pandemic in 2020, is the fact that the hospital discharge of the homeless people was being accelerated. It was being done in a very harsh way. Today, I would like to talk very much about the practicality and what we have faced on the field and explain what were the challenges. So in most cases, we were reported by the homeless beneficiaries that they were not being given the proper medical advice, that they were not offered the full services, they were not explained in detail about their rights during the hospitalization, and whether they were asked to give consent on their medical affairs, and whether they were allowed to seek further advice from outside organizations about their hospitalization. So we were faced with a situation where social services of the hospitals were calling us only because they needed our assistance to convince the homeless patients to move out of the hospitals because they could not be given any further medical assistance. Another example of what our interaction with the medical staff, the doctors or the nurses or the hospital administration, was that there was not enough bed availability, and they needed to move out in short terms, and they needed to seek alternative treatment because their condition was not considered as an emergency anymore. In many other instances also, they were identified as having mental issues, which means that the hospital did not want to take the responsibility to liaise with another institution or another entity that could provide an integrated care for these people. And it was more used as an excuse for them to actually say that we can no longer, our part in providing general services has been completed, and now it is something that needs to be dealt by another medical facility. Overall, we think that what is terribly missing, apart from hard data, comparable data, so that we can actually have numbers and statistics of how many homeless patients have been discharged prematurely, how many of them have been given a full medical advisory prior to being discharged, if there's been any contact with an external organization to provide with additional help. So we don't have this kind of data. And even in the last research of European Union in 2019, you will find that most of the facilities had been also facing their own issues, such as high infection rates, which was turning the experience of a homeless patient even more traumatic, because they were being told that, if they remain in the hospital, their situation would be actually, instead of being better, it would be further aggravated. So what we believe that is a major issue and a major lack in the current situation is that despite having seen some steps forward with putting additional staff in less urban areas and more in the province, so that a larger number of homeless individuals can seek treatment there, we see that there is a complete lack of integrated communication between services in the hospital and external organizations, that there is a big excuse that is being used at the moment, which is the privacy, of the personal information of the patient and the data. So we have recommended many, many times that they should be actually given the opportunity to sign a consent form, and that consent legal form can give the patient the ability and the possibility to collaborate with an external organization, and also to the outside organization, whether it is an NGO or an intermediate care provider, to be able to be part of the overall health plan of the patient. The second thing that we think is missing is that the social work administration of the hospitals is not manned properly. Most of the time, these social services can be part-timers, can be outside the hospital, work remotely, and of course overwhelmed, which means that any contact we have with them, it is only for the purpose of assisting them to remove the patient from the hospital, and also to care for some lacking medical aids, such as walker. Very recently, we had an incident, a very bad incident, with one of our beneficiaries who fell, and he broke the pelvis, and he broke one part of the chest, and he needed a special orthopedic corset, for example, and they couldn't provide it. So through many phone calls with him directly, then finally we were in touch with the social service of the hospital. We were able to provide, we were able to cover the cost, and ultimately we were the ones responsible to, after he was discharged, to transfer him to a temporary accommodation in order for him to become better, because there was absolutely no communication. There was no proper taking care and taking into account what were the needs of the homeless patient after he was being discharged. We believe that if there was a way that the organizations and the social services and the medical staff were somehow participating in joint trainings and joint sharing of information, they would be able to maybe be a bit more empathetic. They would be able maybe to see the patient behind, to see the person behind the patient. And it would also foster trust. It would foster more transparency. And it would also encourage better collaboration between NGOs, between intermediary care, and between the hospital and the medical staff. We did a couple of pilot tests with a couple of the hospitals, the smaller hospitals, and we actually brought a patient in after he was discharged and after he had been transferred to temporary accommodation, to talk to the medical staff about his experience, and to express himself, what his overall care was, and how he felt that he was not, he didn't have access to the same healthcare as the rest of the patients that were in the same ward. And he actually spoke in person to the medical staff to say that his whole experience was traumatized, and he was actually looking also forward to being discharged, because he was lacking the trust that his care was being given in a proficient way. After that exchange, we were invited back, and we were asked to give them some proposals and some ideas of how their experience could be turned better, and how they would be able to understand what role could the NGOs play in such an instance. So from that experience, we feel that if there were better opportunities and more frequent opportunities for the patient, for the NGOs, for intermediary care, and for the medical staff to have this kind of exchange, that this would be a very good way, especially when we know very well that the funding is an issue everywhere. And once we propose, general coordinators, we propose a helpline, we propose a platform, a digital platform that would have, that would allow for a lot of representatives of different organizations and different entities to have access to the patient details with data protection and with the necessary legal frame. We always get the same reply that this is not possible, there is not enough funding. So in a way, we try to be more resourceful and do more practical things that would at least improve the interaction with some of the medical facilities, in a more patient-friendly way. Then we suggested that there is a case management team, in the sense that instead of only being the responsibility of the hospital medical staff and the social services, that if they would allow other members of NGOs or the people who have the street doctors, we have a lot of organizations who also provide primary care, and they can be supplementing such of these services. We asked them if we could all be like a case management team, so that we look for solutions in a collaborative way, instead of just, throwing the ball from one to another. The matter of the fact is that a homeless person at the moment is a person that needs to be discharged ASAP. They are not being given post-discharge medical plan and care. Sometimes we explain there is no supportive environment. And even if there is supportive environment, there is a huge financial burden to the participation of the medication, to covering maybe temporary accommodation, to hosting the homeless person, to looking at other solutions. And
Maria, I'm sorry, just to let you know, two more minutes, more or less.
Sorry,
Okay?
yes, sorry. Yeah,
No
okay.
problem.
So in essence, what today I'm trying to put across as a message is that despite having these wonderful, great ideas of how it could be done, for example, on the gov.gr, which is the main state platform where all the major information of the citizens is saved. We proposed maybe a smaller microsite on that one, but again, the feedback we are getting is no, there is no funding. And just to say that out of 10 cases of homeless people, at least from the amount of data that we have in our hands, the 9 cases have been undertreated. And that is something that we have to worry about, and we have to look at ways of collaborating in a practical manner, so that the funding can support maybe efforts that are not extravagant, because long-term it will not be sustainable. And the way the healthcare is being also in Greece more towards the privatization, I think it will become a much bigger issue. Thank you.
Thank you very much, Maria. I will just give the floor now to Emily Page. She's the Policy Officer, Inclusion, Health and System Change from Pathway from UK. Emily, the floor is yours.
Thanks, Raquel. Hi, everyone. I'm Emily, and was just mentioned. I work for Pathway, who are the UK's leading homeless and inclusion health charity. So Pathway exists to improve the health of people who are facing homelessness and other forms of social exclusion. Okay, a bit of feedback. Okay, cool. And we do this by working with the National Health Service to create specialist hospital-based teams. But before I go into a bit more detail about what Pathway does, I wanted to give a brief kind of overview and account of some of the trends and challenges for homelessness healthcare in the UK, which I'm sure will relate to much of what Maria has just mentioned, and the other panelists as well as where we are specifically in terms of hospital discharge. So we know that people experiencing homelessness are amongst the sickest in our country. They face the most extreme barriers to accessing the healthcare that they need, and they have the poorest health outcomes of any group in our country and our society. And we only have to look at the evidence, which shows that the average age of death amongst men and women experiencing homelessness is 46 and 43, respectively. And this is also a really frail population. So for those people who do make it to their 50s, they are facing disease burdens which are equivalent to those of 89-year-olds in the general population. And there are also huge barriers to accessing primary care and general practice for this population. So although the NHS is free at the point of use, it is difficult to register with a general practitioner or a local doctor if you don't have a permanent address, because you might be moving around a lot. Staff often misunderstand the patient's right to register and turn them away. And also the experience of stigma and discrimination can impact people's trust in these services, so they may not want to approach them. So when we take those factors together, it will come as no surprise that this population is admitted to hospital at a much higher rate than the general population. They attend emergency departments 3 times the rate of the general population. And that number is genuinely rising. So it's estimated that there's been a 33% increase in people experiencing homelessness attending emergency departments since 2017, and a 60% rise in those who then go on to be admitted as an inpatient. And for example, one of our hospital-based teams had a patient who had attended accident and emergency 100 times before any interventions were made. And I think on average they were attending 7 times in a matter of weeks. And what happens is too often those admissions are ending in unsafe discharges, whereby people are being discharged back to inappropriate accommodation, or in the worst instances to the street. So we know that at least 4,200 people were discharged from hospital to no fixed abode in England in 2022 to 23, many of whom were dealing with serious health conditions such as cancer, stroke, complications related to HIV. And because of the way that the data is collected in the UK, we actually believe that this to be an underestimation, and it's likely that the true figure is much larger than that. So this continued practice of street discharge or unsafe discharge is really a result of a combination of pressures. The healthcare system is under huge pressure and financial constraints, with public satisfaction at its lowest. Hospital staff are under huge pressure to discharge patients quickly to free up the bed spaces to address the backlog that we have in elective care. And we are also experiencing housing crisis. So there's a lack of affordable and social housing that can meet different people's needs. So these two pressures are combining in the healthcare system and the housing system to allow people to be discharged inappropriately and safely before they are ready to be. And by discharging people back to the places that made them sick to begin with, we put their health at risk again, which perpetuates the cycle of readmission to hospital and just adds to the pressure on the healthcare system. However, I do want to focus a bit more on the solutions, just to make it a bit more positive. And despite the context being incredibly difficult and challenging, there are solutions that are very well evidenced. as well as cost effective for public services in the long term. So there are two key solutions that Pathway advocate for. So as I mentioned earlier, Pathway works with local NHS trusts to create specialist hospital-based teams that work to improve hospital care and discharge for patients who are experiencing homelessness. So at the moment, we have around 8 teams in operation across the country. We have 5 in London and 3 in the north and south of England. We also have one team that is actually coincidentally launching today in Wales. So that team is about to become operational as well. And all of these teams are clinically led and multidisciplinary. So they usually comprise of a combination of a general practitioner, a doctor, a nurse, a housing worker, social workers, occupational therapists, and care navigators. And all of these people work together to provide holistic and person-centered support to patients who are facing homelessness in acute hospitals and mental health hospitals. And to give some examples of what that might look like in practice, a team would be meeting the immediate needs of a patient, so providing them with fresh clothes, helping them to make contact with their friends and family. They obviously provide the medical treatment in a trauma-informed way, and they will support with providing or finding appropriate accommodation on discharge. They'll also look to make sure that the patient is registered with a general practitioner and other support services such as substance misuse services, so that they have that network of support in place when they are ready to be discharged. And some of our teams also have access to legal advice. So in the UK, we have the NRPF condition, which is no recourse to public funds. And that prevents certain people from accessing public benefits depending on their immigration status. So legal advisors are able to support those patients to know what their rights are and to plug them into support wherever possible. And we know that this programme is effective. So the Pathway teams reduce breast sleeping on average by 50%, with the most successful teams by up to 82%. And some of these teams have connections to specialist intermediate care, and that's the kind of second key solution that I wanted to mention. So intermediate care is sometimes referred to as step-down care or medical respite, but for us what this looks like in practice is a safe place for people to recover when they are medically ready to be discharged from hospital, but otherwise wouldn't have a safe place to go to. So it's a form of short-term or interim accommodation that has a focus on recovery. So it will include medical in-reach support. So for example, that might look like an advanced nurse practitioner coming to the service every day to help patients redress their wounds and things like that. But there's also a strong social support element. So workers there will be helping patients to schedule and attend different appointments, like doctor's appointments, or apply for welfare support. And there's also coordinated planning around more permanent housing. So those services, like I say, are interim. They're designed to be with patients for around 6 to 12 weeks. So the idea is that it offers a safe place for people to go to, that they can then look to find more suitable and long-term accommodation. And again, these services are proven to be beneficial to patients. They reduce breast sleeping as well as readmissions to hospital. And Pathway have also recently published research that shows that these services are cost effective. So they save money through the reduction of delayed discharges and readmissions to hospital, as well as the benefits to broader public services. So for example, the criminal justice system, they help to break that cycle and free up resource for other services. Unfortunately, as it stands in the UK, despite all of this good evidence, there's currently just not enough of the specialist hospital teams or intermediate care for those who need it. And what we find is that these services tend to be continually piloted, although we know that they work, or they fall victim to short funding cycles. So they will be funded for a fixed term, and when this funding runs out, the services then can't survive. So to summarize, pathway, we're really calling for a shift in policy and provision to improve the care that is one received by patients experiencing homelessness during a stay in hospital so that they can improve their health and kind of send them on that upward trajectory. And two, by providing the safe places for people to recover after a hospital admission to make sure that they maintain that good health and to prevent future admissions to hospital. And for that to be achieved, these services really need the kind of long-term and ring-fenced funding that we don't have at the moment.
Thank you, Emily. I will just pass to the next speaker, Guilhem Fernandez from Advocacy Research and Evaluation from AGEL's Fundación from Spain. Guilhem, you can start your presentation.
Okay. Good morning, everyone. Thank you for inviting us to the webinar. I will present you part the results of a survey we carry out as a Rails Foundation to 685 people who were living on the streets, the situation 1.1 of the ethos typology. Well, right. Can you see the slides? Yes.
Yes, you can see.
Page.
No.
Yeah, I will try with this one. Maybe it's better for you. Yeah. Okay. Well, the report deals with the different health aspects, the health status, the barriers access to, or state to the health system, and mortality. But today we will focus only in the second point. In reference with the health coverage, I think the idea here is that we can see that 1 in 4 of road sleepers in Barcelona still doesn't have coverage within the health system. It's true that in recent years, this percentage of coverage has improved because in 2021, only 55% declares to have a coverage, and now it's 74. But women, young people, and foreigners, and those have spent less time living on the streets are who declare don't have health coverage. This is yeah. Like we can see that how the coordination between social services and health services is essential for facilitate access to health system, because the 82% of people who receive social support have health coverage. On the other hand, the 36% of those who have not received social support don't have coverage. This is an interesting link. Road sleepers to healthcare system is more successful when it is mediated by social workers in outreach teams, in our case, because we have an outreach team and we are developing this work. But they have the link and they understand better their needs and the 60% of the road sleepers declare that they have received medical care in the last 6 months. And going deeper into this idea of the social support and medical care, we can say that this relationship is very strong, because almost 70% of people who receive social support in the last 6 months have also received medical care. This is interesting data, and this one is another fact that the health coverage and the type attention, we ratified other papers and other reports, but it's people who don't have public health coverage tell us that the medical visits that they have received in the last 6 months have been through the emergency services. This is the 63% of people. And in people who do have the coverage, predominates an arranged visit for the 62%. This is, for us, maybe it's very clear, but the voice of the homeless people is strong. The next one slide. This 65% of people didn't receive attention from any social worker when they were admitted to hospital. This is interesting because we have maybe there are different reasons here for it can be explained this. The first reason maybe that the person's situation is not known by the hospital or by the screening department, and he doesn't declare it. And this is a typical situation that we found. Other situation maybe is that people's perceptions of hospital admission is not the one applied by hospitals. If you spend 3 days in the emergency room of a hospital and then leave, here in Catalonia, in Barcelona, it is not considered like a hospital admission by hospital. But maybe for the people, yes, because they are in the emergency room in the hospital. But the protocol is different. And other reason can be that the possible burden of the hospital social workers teams. This is another reason that we can found and can explain this kind of situations. This is maybe the important data here is that a direct consequence of not receiving a visit from a social worker during the hospital admission is not being able to prepare a good exit in the process of medical discharge. Because here is the only 13% were offered accommodation when they were medically discharged in this case. And although in most cases, the problem is previous, because the problem is already that in the screening process, because they not attend me and not offer me accommodation, In percent who have received care and have not been offered accommodation. We don't know if it's because they didn't have one or if they didn't need it from a medical perspective. But probably it's clear that when we talk in the qualitative interviews that they don't have enough housing or accommodation for people who are in the hospital admitted. And other consequence of all of these things is that 1 in 4 people is not able to take any prescribed medication then. This percentage for us seems lower than we would find every day at Rails Foundation. Because in many cases, the treatments for diseases that don't disturb me or don't cause pain or no limit the person, they are not followed, This is the point is this treatment, it depends of everyone, but a lot of people, they don't follow this in all Spain. This is very cruel reality because the pain, the everyday life is very painful. Okay, conclusions, very brief conclusions are that there are still people excluded from health coverage. The healthcare system is inflexible, fragmented, and makes it difficult for homeless people to access and stay. This is the idea. And there is a direct relationship between social care and medical care if we want to improve services and attention to homeless people. And there are not clear protocols and enough stable residential resources for homeless people living medically. The fact that is very, very, very clear. And maybe for proposals, we will discuss later. I mean, for me, that's all. We deeply appreciate the contribution of the homeless people who participates to this surveys and all of the people who make it possible. And yeah, this is the presentation. Thank you very much for your attention.
Thank you for your presentation. And now we will listen from Elisabetta Notarnicola. She's the coordinator of the Social Policy and Innovation Unit from Sergas, Bocconi University, Italy. Elisabetta, the floor is yours.
Thank you, Raquel. Thank you. Before sharing my slides, just a couple of words introducing our work at Sergas. We are doing research on how policy and services are functioning for what concern healthcare and social care. So the topics like the one we are discussing today that put together the two sectors are really interesting for us. And in the last years, we have been focusing a lot on inequalities and vulnerable populations and how to support equal access both to social care and healthcare. So today I share my slide and ask Raquel to tell me if you can see them properly in a second. Now they should be, okay, thank you.
Perfectly.
So what I would like to discuss with you today are the results of two research initiatives that we have been doing 2023, 2024 with a focus on Milan metropolitan area. So Milan is one of the biggest city in Italy and one of the cities in which the phenomena of homelessness is the hardest. The topic is someone, let's say, a step behind the process of hospitalization because we were looking at the level of integration between three pillars of interventions for homelessness, and mainly the three group of factors that are involved that in Italy are the social care sector led by the municipal level, so in this case, Municipality of Milan, then the healthcare sectors with the local health authority that is a public agency, and then all the not-for-profit providers, third sector organizations that both offer their own services and then also work in coordination with the social care municipal level. So I just want to acknowledge the colleagues with which have been working with in the last 2 years with for what concern the two projects. But going straight to the topic, you see, this is the situation in Milan, the map of the city that shows the concentration of homeless people. These are really brand new data because last year there was, 2 years ago, sorry, there was a research on the field collecting information, gathering information directly from homeless people through face-to-face interviews. So we have pretty nice data about where homeless people stay, who are that they and also which kind of needs they have, which kind of also request in terms of both social care and health care. You see, I guess that you might already know, but you see that homelessness in Italy is really linked with migrants, asylum seeker. And you see here that the majority of the people that are homeless are in this condition due to the lack of official documents and because they are people in a migration path. So this is just to give you a background of who we are talking about. And the Milan case was really interesting because the topic of working better so to have better integration between the different actors with the final purpose to offer better services and better and higher level value, to the homeless people was really a big objective, at least for the municipal level. So back in 2019, some innovations were started from the municipal side, so to promote better integration, starting from what happened of what concerned the social care services. So they were really working on integrating themselves, the municipality, and the staff working for the municipality with all the organization and staff working for the third sector organization and not-for-profit provider. And basically, three area of innovation and then also solutions were implemented. One first innovation was opening a new physical hub that is called San Martini Center, a physical place in the city where they were able to integrate both services, because physically some services for homeless people are organized and then also provided there. And this implied that the professionals from the municipality and the third sector organization work there together in a physical space. So sharing not only let's say the facility, but also sharing the approach, sharing the fact that they work together with the homeless people. Then a second initiative was really devoted to the topic of co-planning or co-design process. So starting from 2019, the municipality started to work really, let's say, in a strategic way with the third sector organization, because they started a very participatory and open process of co-planning and co-design, both in terms of how to use some resources, for example, international EU funds, and also on how to design new intervention. And then the third tool, the third solution was an information system, a shared information system through which the municipal level and the third sector organization were able to share data and information about single individuals, homeless people, and the intervention provided to them, let's say the state of the art of that specific case of that specific person, with all the updates about where the person is, which is the current state of health, which is the current social status in terms of, okay, what is happening to that person day by day. And so they now are able to share very instantaneously information about what they are doing for people. So this big investment, as you can imagine, really produced some results. And on the other end, we had two big topics that remain totally, let's say, there untouched by innovation. And one is what we are discussing today. So the fact that, on the contrary, the integration with the healthcare sector, the healthcare services and providers that are mainly public in terms of who is working with homeless people, is completely lacking today. So I cannot say that there exists some discharge pathway. I cannot say that today we have some mechanism or protocols that make working the connection between healthcare sector and then everything that is social care, even disregarding that is led by municipal level or third sector organization. So this remain a big issue, and remain also another big issue that is out of scope today, the fact that the housing sector is really critical in this very moment in Milan. But just to show you that what they try in terms of supporting the integration within the social care was really working, because our research was oriented toward collecting data and evidence about, okay, the level of integration that they were able to reach after this free innovation were introduced. And here you can see the results of a survey that present the perception of the staff working with homeless people. So this is related to the co-planning, co-design process. We asked them, okay, but what is today the level of coordination and integration on strategic objectives? And you see that both from the municipal point of view and the third sector point of view, they have now achieved sufficient or a very satisfying level of coordination for what concerns the, let's say, strategic vision The same happen if we ask them about, okay, are you now able to integrate your services specifically? And again, both from the municipality and the sector providers' point of view, they have achieved now sufficient or very satisfactory level of integration and coordination. Let's say positive, but not as positive as for the previous slides result we had for the sharing of information system. Here you see we asked them, okay, but are you now, due to the fact that now you have a shared information system, are you now happy of the level of exchange of information that you have? And in the sense, still we can see that there's a very positive result. So the percentage of people that say it's sufficient or satisfying is the majority, but somehow lower than what was for the strategic vision and integration of services. This is a premise to say that for what concern the integration, let's say within the perimeter of social care intervention, some tools and approach so to have better integration have been tested, introduced, implemented, and also they are proving their effectiveness and their results. What happens if we look at the level of integration with the healthcare providers? So we ask both the municipal staff and the third sector organization, but are you happy today of the level of integration with what you are doing in terms of social care and the healthcare providers that operate in the city? And in this sense, we intended the local health authority. And you see that in this case, the majority of the answer was, okay, it's totally absent the level of integration or not sufficient. So on one hand, the integration with healthcare was not part of the innovation promoted starting from 2019. So one could say, okay, no investment was made on supporting integration with healthcare. So it's kind of normal not seeing this kind of results. But this can be seen as also the consequence of the fact that it wasn't possible to really promote some innovation in this sense, but still we have a big need of working on this integration, because if what happened within the social care perimeter, we now can say that we have some satisfying level of integration. It's really critical, and I do not have to go again through why it's so important to integrate also with healthcare, because you have already said that. But this figure just show you that it's so difficult, but still very important to work on that. And hospitalization is the thing. Here you see also for Italy, some figures that show you that for vulnerable people, and here the figure is not specifically homeless people, but it's migrants. But what we know that in Italy, homelessness and migrants really are targets that are overlapping. You see that both in terms of how much the healthcare system spend and also in terms of how much services that are provided, the hospitalizations and also the emergency department activities are those on which they are investing majority of resources when it comes to migrants, and we can also say the same for homeless people. In a second research project where we have been working not only with the municipality but also with all of these first sector organization, we try to understand better how it works, the integration with the healthcare system, healthcare providers. And then I know that I still have 2 minutes, but I'm almost finished. And here you see which are the results. So we ask a third-profit organization operating in the healthcare, so providing healthcare to homeless people. Okay, but exist some links between you and the NHS, the local health authorities, in terms of, okay, who is sending you the homeless people for which you provide services, healthcare services. And you see that majority of situation, homeless people have direct access to not-for-profit provider that provide them healthcare. And only 15% in the case, they have some explicit and connection in terms of pathways, procedures, or protocol that bring together the not-for-profit providers and the NHS in terms of following the same person when it comes to healthcare provision. The same happen also within the not-for-profit providers. And the second picture in the slide show you that exists some networks, some relations between not-for-profit operating in the healthcare sector for homeless people. So they have some relations, they open some collaborations, but these are not, let's say, institutionalized yet. I mean, it's more based on professional experience. So the single professional, I don't know, physician or whatever, or nurse has some relation with other or are psychiatric. And so they try to push some relational collaboration thanks to that, but not something that is really part of the system. We ask them, okay, but why it's not happening? So which are the reasons for which it's so difficult today to have this integration with the NHS? And here you see which are the gaps from the not-for-profit provider's point of view. Lack of mutual knowledge, lack of data sharing. So we go back to the topic of having the information system that appeared to be very useful in the social care area, but also lack of protocols, then lack of tools, and the topic of having, let's say, too much work. So both the NHS is under pressure and also the not-for-profit providers working with homeless people. The same is true and is reported if you interview people working from the NHS. They also add the fact that maybe the professionals have very high mutual expectation in terms of integration that can be achieved, but it was interesting because they say maybe it's just that it's so hard to integrate ourselves and it's so difficult because the story, the personal story of the people, homeless people, is so complex. And these produce the fact that it's so hard to have sharing of information and building pathways to follow them. This is the same question as before, but just sharing, let's say, the ranking of which are the criticalities. And you see that the one that have the highest percentages are really linked to institutional capacity. So as a conclusion, we can work on institutional capacity. So if the topic is, okay, all the organizations working there have saturated capacity, okay, we can work on that. If it's that we know more structured collaboration, we can work on protocols and tools. Then you have a bunch of elements that are more connected to the strategic vision of the integration. So we have to work on languages and method. We have to share data. We have to produce knowledge across the sector and between organizations. And also in this sense, we can work on that. And then less remarkable, but still present, only 20%, 10%. Also pointing out some cognitive, let's say, elements. So maybe someone is not still very convinced about integration. Little desire to collaborate might be there and might be also linked to different visions or values. This was just to provide some backgrounds on what is working, what is not working in Milan, and also what still need to be done so to foster integration. And thank you.
Thank you very much to all of you for such great presentations. It's really good to have the background and all other presentations, even though they come from different contexts and perhaps different levels. I think they bring forward several common points, and it is very clear that the work you do it's in the context of a myriad of challenges. First of all, we know that in general, homelessness has been on the increase in the past decade or more, and it is harder and harder to ensure that people have access to rights in this context. I think several of you also highlighted the issue of lack of data, and it's difficult to work towards solutions when you don't know what are the needs and what challenges have to be more specifically addressed. And then there is, of course, the challenge of financial means, which investment in the health systems in general has been highlighted, and then more specifically when it comes to
so-called vulnerable groups. In our case, people experiencing homelessness, more investment is needed, of course. And then we have the fragmented and inflexible health systems. That was also an issue raised towards which civil society organizations working on health and homelessness have been trying to address this issue with solutions. But then again, I think, Emily, it was you who mentioned that these are pilots. They are short term. So we need more attention to that as well. And not last to mention the fact that there are different cases, different profiles of people. Migration has been mentioned a couple of times. That is also something that we at FEANTSA have been focusing on in this period. And of course, things like lacking health insurance or precarious administrative status will have a great impact on the type of care that people can access. So we should not forget about that. I do appreciate that you mentioned a lot of solutions that were implemented, and despite the remaining challenges, this should be scaled up and promoted, which is what we're trying to do with our webinar today and through the paper that we've been publishing earlier this year, which Raquel mentioned earlier and is available on our website. And one point that you mentioned, Elisabetta, the lack of housing stock, of course, that is something that you said is not the topic of our discussion today, but it is very much the issue that the general context of our work. So on that, there have been a lot of developments at the European level. We hope to see fruits in the coming period. There are some questions in the chat. Perhaps we will start with this. I would like to remind everyone that this is the moment you get to raise your issues, ask our speakers questions, or share from your own experiences. We would love to hear what is happening in other countries on this topic specifically. Maybe we can start with the question from Michaela at Caritas Austria, if she's still with us, I hope. She says that they are running 2 projects that aim at medical care for homeless people, a mobile bus with basic medical care and a short-term living project that allows hospitals to release people to their care, similar to what Emily described. And however, she says it is not the inclusive approach that she would prefer because it's still targeting only homeless people and doesn't provide the level of care that people who are not homeless have access to. And her question is, what is your viewpoint on this? Is it realistic to work towards more rights, better healthcare, or is it the way to go forward to provide separate projects and solutions? And I think this question relates to something that we've been also debating within our membership, and what is the role of the homelessness sector overall? Should we develop what could be called a parallel system for health when it comes to people experiencing homelessness? Or should we advocate for mainstream services? It would be interesting to hear all of your opinions on this. Maria, if you would like to start, since it's been a while that you spoke.
Thank you. I believe that expressing, as I said, the experience from the field, I believe this has to be a dual effort. We need to fill the gaps in between because we are losing people in the process while trying to advocate for more integrated solutions and for more, I would say, all-rounded sustainable solutions. Because at the end of the day, we come across incidents on a daily basis, and somehow there is an ethical dilemma of do we put more resources into advocacy and promoting sustainable solutions long term. Lack of housing, as you mentioned, is a huge challenge. A country like Greece with a massive tourist inventory is experiencing this on a daily basis. Shortcuts in health funding. As Elisabetta mentioned before, I was quite jealous actually to hear about the cooperation between municipality and non-profits and all the other parties. We know very well that in other countries in the Mediterranean, we don't have these long-term collaborations because the players keep changing. So it's very difficult to enforce a sustainable also communication channel. So my answer is that we need to look after the people during the process of trying to find more sustainable solutions, because like in COVID, the loss of life was terrible. And that adds also to the frustration of the people, the staff and the teams of the non-profits and all other parties who are dedicating so much effort in looking after the homeless, the hospitalization of the homeless people. And yes, in an ideal world, it should be an overall policy. It should be streamlined through the state, but having also some alternative solutions will contribute to saving lives and to maybe gaining time until such integrated solutions are in place.
Thank you, Maria. Emily, would you like to add something about your experience in the UK on this balance between advocacy and providing services?
Yeah, I think it's a really good question. It's something we kind of battle with quite a lot in Pathway, is whether we advocate for the specialist programs or whether the idea is to embed our values into the mainstream provision so that people experiencing homelessness can be treated and cared for in the same way that everyone else would be. And what we find in the UK is that any kind of resource or capacity for this population is always seen as a nice to have by the local systems who are responsible for commissioning the services. So rather than it being a kind of directive target that needs to be met, like it is in the general population, it's kind of, if there is enough capacity and resource, if there is enough money, then we will provision these services. And of course, there never is enough capacity and there never is enough money. So these people are constantly kind of slipping through the gaps. And I think the exclusion that we see is so extreme that specialist services feel more important now than ever. But saying that part of our hospital team's role is not only to support the patient directly, but also to educate other hospital staff and the broader system to better meet the needs of those patients. So part of their role is to create that culture change. And we do a lot of work at Pathway in terms of education and looking at how doctors and nurses are educated in the UK and whether we can embed some of these values and understanding of homelessness kind of at the very beginning of their education and careers. So I think the big cultural shift is definitely a long-term goal, but right now it feels like the specialist services are the only way to make sure that these people's needs are met.
Would you like to add anything to this, Guillem or Elisabetta? Feel free.
Well, I think in Catalonia here, there is a homelessness care plan that is a combination of social services and health services. Hence is being created to be able to share data from the social system and the health system. This is a very interesting point. But this is causing that that different hospitals and primary care centers they are open to work with social entities now. And right now we are going out on the streets together with workers from primary care centers here in Barcelona, so they can meet those people who will never go to the doctor if they don't have a crisis. And this is our idea from the very basic and practical case. But at the same time, we are doing training and political advocacy, as with the report I presented you. This is our idea, because we are working with the human rights perspective then. And we work very close with the official College of Doctors and Nurses, and we create a manifest with 10 points to create new measures and protocols in the health system. Then we are trying to change the health system and the social services, because the idea is they need to be open-minded to create new resources for homeless people, because the public system, they are not adapting for a reality with dual pathology, for example. They are looking for general solutions in a big hospitals and a big issues, but they are not creating specific resources for people, for example, with mental health problems or alcoholic problems. This is the point. They are not creating different solutions. They are looking only for efficient and big general resources. And this is a problem, because not everybody can enter to these services. They cannot stay there.
I may add. Yes, I totally agree with Guillem. I mean, having equal access to healthcare does not mean that you should have the same healthcare for everyone. So, as it was put in the message, is it inclusive to have different and, let's say, separate healthcare services? I mean, I don't know if it's inclusive, but the way we can make homeless people have the access to healthcare. So the objective is to have equal access from my point of view. And as well as how Guillem was saying, the healthcare sector is not really on this point of view, because the idea there is to have, since NHS is really under pressure in our countries, the idea is to be efficient, to be effective, so to standardize, so to be able to answer majority of people possible. And social care approach is exactly the other way around. So have targeted intervention, really personalized, so to provide the best solution for that single individual, not for the, let's say, majority of the population. So we need some adaptation between these two, and it's not a case that the integration between the two sectors is so hard. I mean, today we're talking about homeless people, but hospitalization discharge is a mess for all the categories of vulnerable population. If you think about elderly and fragile elderly, for example, I don't know how it works in your countries, but what it is in Italy, and we are doing research on that, and we have evidence. Well, after an hospitalization, a fragile elderly happened to a fragile elderly exactly the same thing that happened to a homeless people or person. So not any type of organized discharge is there. So it's really, I think in this sense, the topic is broader than just focusing on homeless people, but then you have to have targeted solutions for the specific group of people, because they need some really, let's say, again, targeted services.
Thank you all for sharing that. Michaela, yes, if you wanted to come in as well, you are welcome to share from what is happening in Austria, but no pressure, of course. To move forward, we had another question in the chat, which it was meant for Emily, but I believe it can also be answered by our other speakers from their own experience. The question is, you mentioned that the number of patients discharged to the streets is underestimated in the UK, which I assume is the case in other countries, or maybe also not known. What kind of data or evidence would you like to see to help plan or evaluate schemes which support people who are at risk of unsafe discharge? Emily, when you answered this, maybe also answer the other question that was in the chat for you, which says, what are the areas that your teams are working with?
Yeah, so the data on people being discharged from hospital to the street was collected through freedom of information requests. So that is a technique that anyone in the public can ask a government body for information, and only half of the trusts in the UK responded to that request. So I think there's around 112 trusts altogether, and around 50 of them responded. So in theory, that statistic could be at least double the amount. And the reason we had to go through that route is because hospitals don't routinely collect data on patients who are experiencing homelessness. So hospitals don't collect data on discharge destinations. So that is something that is kind of needed to know the true number of people who are being discharged without any care and support in place. And I think there's something around the understanding of homelessness in the healthcare system as well, because in the UK we go by the core homelessness definition. So that includes rough sleeping as well as people that might be more hidden, so people who are staying in temporary accommodation, but are actually there for a very long time and it's not very temporary, people who are sofa surfing or staying with friends and family or sleeping in places like cars and sheds. And actually what we find is that hospital staff don't have the education to be able to ask the right questions, to be able to understand people's housing status. So having that regular data and routine data collection of when someone is admitted to hospital, what their housing status is, and then when they are discharged from hospital, what their housing status is. That's the data that we'd really like to see. And I can share, we've got lots of resources around healthcare data, which I can share with you. On the other question around where the teams are in the UK, so the way that the funding is quite inconsistent because it's based on the local area, so the teams can change quite quickly. But at the moment we have teams. We have 5 teams in London. We also have teams in the north of England, so places like Hull and Leeds, and we also have some in the south, so Plymouth and in East Kent. And I can share a link to all of those teams if that's useful.
Thank you for that. Maria, I will go to you again because in your introduction, you already mentioned this issue of the data and also in connection to the follow-up work that the caseworkers can develop, and the issue of privacy was also mentioned by you, I believe. Do you want to develop a bit on this?
Yes, and actually, as Emily was speaking about areas in where they operate, I also wanted to mention on this subject that we also saw a distinct difference between the behavior of the homeless patients towards discharge inside the capital and outside. And I think I mentioned in my initial presentation that the trust towards the healthcare in areas outside of the capital, like on the island of Crete when we had the earthquake, or when we dealt with a lot of people who were temporarily homeless due to extreme weather phenomenon, it was a lot less. It was the trust towards the medical system was a lot stronger. which means that we were actually told by the head of the main hospital of Crete that the homeless patients were actually asking to be hospitalized, treated, and in some ways try to enter a more sociable environment where they could be looked after, versus the situation in Athens where they wanted to be discharged as soon as possible. What I'm trying to say is that there is a difference in the cultural approach from the patient towards the hospital. And we saw that the consent they gave for sharing the data was a lot easier. So in smaller places, in smaller societies, we see that it is easier to implement ways of patients giving consent for sharing information in order to find additional services after the discharge, such as temporary accommodation, such as mental health services, etc., etc. In the city, this is very difficult, and unless it is done in a trustworthy way, in a way that the patient knows that this information will be used only for his own benefit, I think it will be a lot harder to achieve. So it has to be done in a legal framework, but also giving the possibility of having access to this information in order to have this famous case working team, because that will definitely make a big difference. And as I said, the solutions will be shared amongst different parties. And in places where there are yet a lot of efforts to be done for having a protocol, let's say, or a unified way of dealing with this, it can be quite helpful.
Thank you. I would like to pick up on this unified way of work in a minute, but not before we go to Guillem and Elisabetta, if you would like to add anything on the point regarding data collection.
Well, from my point of view, I think that the issue of the data starts in the screening room. And I think it's not only which kind of people will go to the streets or how we can discharge, but we need to be preventive. We need to create links with homeless people before they have crisis and before they go to the primary attentions. When we have this, we are with this test that I told you, we have these 10 points. The first point is to create a homeless code. We need to create a homeless code because it's not for stigmatize, it's more for to be efficient in the whole process. Because we have, in our report, we put the attention that the 65% of the people don't receive attention from any social worker when they were admitted to hospital, because nobody recognized that they are homeless. Nobody asked anything about if you are sleeping on the streets or what are you or where are you sleeping. Then in whole process, they are not homeless. Then they cannot discharge and they don't enter in the protocol of I need to call there. For me, we need to create a new picture or a big picture. Because the process of discharge starts in the beginning.
And regarding data, so any kind of data, I mean, we do not have data in Italy about homeless people, or at least we have very poor data, no national data sets, and also the topic is really underestimated when we look at healthcare data. We have very strong and powerful healthcare information system, so we can know pretty everything about healthcare consumption for an average citizen, but no specific information for homeless people, and the same for social care. So any attempt to have new data is something that is useful, and municipalities are adopting some bottom-up strategies to collect their own data to monitor what is going on. And I take this opportunity to say that we are really open for collaboration, because I think that research and what we can gather from the feed from organizations like yours is really informative in terms of data we can offer to the policy level. So I think that data should also start from all of us. I mean, start collecting our data and then providing this data to the policy level is something that is really important.
Thank you very much to all of you. We have 5 minutes left, and I think we can already start to wrap up unless there are any last-minute questions from the audience. Just checking one last time. This is the moment if you want to intervene or ask anything else. Otherwise, from my side, I did want to go back to the unified approach, and this connects to all the points that you raised here about data and about knowing more about what is happening across Europe, and also to connect with the mention that Raquel made in the beginning on the European platform on combating homelessness. Because at the moment, this is the wider framework that we work in. And this is also relevant because it's an initiative to which all EU member states have committed, and who also has as one of their main goals that to make sure that nobody will be discharged from any institution without an offer of appropriate housing. And of course, the platform works towards this goal until 2030, and then we will see what happens. FEANTSA has a very active role in this platform. I believe some of our Epoch Practice colleagues are present here today. If you don't know about it, you can go on our website and read more about the initiative. Epoch Practice is implementing a lot of activities currently until the end of the year under the European Platform on Combating Homelessness. So to end this webinar also with a positive thought, I would like to invite you to make a short recommendation or any last thought that you may have on discharge plans that are providing for everyone in this context of this conversation today and of this work on ending homelessness. Whatever you want to share with us as a closing remark. Thank you.
Do you want me to start?
Yes, please.
Okay. Culture shifting, open days, educating about the needs of homeless people, making sure that they are identified, not because they should be stigmatized, but they are identified because we should take into consideration their needs. And to speak from own experience, discharging is not a way of shifting the problem to someone else, but discharging means that you take the necessary measures so that your patient does not return so regularly and so often, maybe in a worse situation. But the discharge is done in a way that it becomes part of the solution of the problem and not aggravating the problem. So we need to look at things in a more holistic way. And as I said, I think only in a unified way I can foresee a sustainable way forward. Thank you. Thank you very much for this.
It's okay if I go next, or I have to rush off quite quickly in a minute. I think my final comments would be, in an ideal world, we'd like to see the care of people experiencing homelessness in hospital driven up. and to address and identify people's needs on admission, I think was mentioned earlier. So not waiting until someone is ready to be discharged to then start planning around discharge. So for that to happen on admission, and also for there to be more safe places for people to recover when they are discharged from hospital, so they have somewhere to go to. That's me. I'm sorry I have to rush off, but thank you for having me, and I'm happy to be in contact with anyone or share any resources.
Thank you for joining, Emily.
For me, the idea is to understand that housing is the first thing that we need. Nobody needs have to be in the street, and then this is the first point. Is like is a structural measure that the different states need to take into account of this. And the other thing is that I think that we need to know the reality of our cities and our streets. If we don't know what is not a priority to know this, we cannot found solutions or permanent solutions for people. Yeah, from the equality access of health system is a basic issue.
Thank you. Maybe I just add that we have also to consider professionals, because I think one point is that we are looking at how services are arranged, how they work, but then services are provided by people. So we have also to invest on how professionals in healthcare see the homelessness phenomena, and also the knowledge they have. I think they have poor knowledge somehow. They are not trained in treating with vulnerable people. They're really training on the clinical part, you see. So also working on making them aware of the needs and why integration is so important, not just to have the services going smoothly, but for good of the people. I mean, also that.
Okay, so I think we will finish the webinar. Thank you so much to all our speakers, to your information that you share in your presentations. I think we really had an interesting discussion, and thank you to everyone that is here with us today. So yeah,
Thank you. Have a nice rest of the day. Thank you so much for your speeches and questions.